is Dr. Janet Helminski. She's a professor in physical therapy at Midwestern University and a physical therapist at the Physical Therapy Institute at Midwestern. She received her PhD in neuroscience from Northwestern University's Institute for Neuroscience, her advanced Master's of Science degree in physical therapy from Northwestern University, and her Bachelor's of Science degree in physical therapy from Marquette University. She specializes in and lectures extensively on the management of patients with vestibular dysfunction. Her areas of research include strategies to prevent recurrence of BPPV, evaluation and treatment of atypical BPPV, and central adaptation of the vestibular system. She was a recipient of the 2015 American Physical Therapy Association Jack Walker Award for her research in BPPV. So, Dr. Dan.
Thank you. So today, what I was going to do is I was going to talk about acute vestibular syndrome and how you differentiate somebody who has a central versus a peripheral dysfunction. And normally I talk on BPPV because my love is BPPV and my passion is BPPV. But I decided to do something different just because the hot topic right now is how do you differentiate central from peripheral in the emergency room. And a lot has been coming out and a lot of PTs are starting to get involved with it. So I decided it might be a good topic to talk about with a general audience. So I'm curious in terms of in this room, how many of you treat vestibular patients? Okay. How many of you have goggles? Okay, good. Okay. So this is intended to be an overview. And so if you're listening to this and you think, oh my gosh, I have no idea what she's talking about, my recommendation is that you can take a course. And the courses that I recommend you taking are with the American PT Association. The Vestibular Special Interest Group developed an introductory and an advanced vestibular course, and they rotate around the country, and they're excellent. And so if you need more information, that's a place that you can go. And with that, I'd like to get started. So what we're going to do is we're going to discuss the pathophysiology of acute vestibular syndrome to interpret exam findings, describe a structured diagnostic algorithm to assess acute vertigo without focal neurological deficits. And so this is the key. We're talking about an algorithm that was developed by a group in Italy. And it's for people who are coming in who are dizzy and have no other neurological signs. And then to try to interpret the neurological findings to determine if the diagnosis is peripheral or central. So vertigo and dizziness account for 4 million emergency department visits per year in the U.S. And of those cases of vertigo and dizziness, 33% are due to otologic causes. And the symptoms that you see are rapid onset of severe continuous vertigo or dizziness, nausea with retching or vomiting, gait instability, head motion intolerance, and nystagmus. And usually it evolves over days, over seconds to hours, and usually the symptoms last anywhere from days to weeks. So if you look at the symptoms for central and peripheral are the same. So what you need to do is you need to look at the signs to try to differentiate whether or not it's central or peripheral. 75% of acute vertigo syndrome is peripheral in origin, with 25% being central, coming from the brainstem or the cerebellum. Of the cases that present to the emergency room that are central in origin, 35% are misdiagnosed, so it's a huge population. And of the emergency room visits that are central vertigo, 4 to 6% are vascular in origin. And if you miss the diagnosis of central vertigo, you're at greater risk of having death or an 8-time increase in fold of death. So of the patients who have central vestibular dysfunction, A lot of them do not present with other signs and symptoms, and so it's a very focal lesion. So it's important that you try to differentiate the vertigo in terms of if it's central or peripheral. In the first day, CT scans can only identify 16% of posterior fossa stroke, so if you're relying on a CT scan, you're not going to be able to differentially diagnose. And of MRI with diffuse weighted imaging, only 80% of posterior fossa strokes are involved. Realize that if it's central vestibular, it's a posterior fossa stroke. It's not a internal carotid artery stroke. An internal carotid artery stroke is your typical garden variety CVA with a hemiplegia, versus your posterior fossa strokes are your dizziness, vertigo, and ataxia. So clinically, it's important that these people are accurately diagnosed so that they get initiation of appropriate treatment, and you try to prevent adverse effects. So what I'd like to do is just very briefly go over the anatomy and talk a little bit about the control of eye movements. So we know that there are 6 eye muscles. And that the 6 eye muscles work in pairs, and that the pair of eye muscles generate eye movements in 9 different planes. And what this is showing you are the 9 different planes, and for each direction, it's showing you the pair of eye muscles that are controlling the eye. And then if you look at the 6 different eye muscles, they're innervated by 3 cranial nerves. And if you recall, the 3 cranial nerves are the ocular motor nerve, which is located up in the midbrain, the trochlear nerve, which again comes around from the midbrain and comes around up in front, and then the abducens, which is located down in the pons. And this is just showing you a picture of the brainstem, and again you have the midbrain, the pons, and the medulla. And in case you've forgotten, the vestibular nuclear complex is back here on the floor of the 4th ventricle, and it's at the junction of the pons and at the medulla. So it's right in the middle of where all these eye movement centers are located. And the key point that you have to remember is vertical eye movements are generated by the midbrain, so up in this area, along with vergence. So a lot of times with your patients who have had a mild traumatic brain injury, they'll have vergence insufficiency. And the vergence insufficiency is because they'll have stretching that'll be up in the midbrain area. The pons, which is located down in here, is going to be responsible for generation of horizontal eye movements. And because these are cranial nerves and because they're lower motor neurons, if you have damage to the cranial nerve nuclei or the nerve as it's coming out, it's a lower motor neuron injury. And in terms of for the eye muscles. The other thing that's important is if you look at the insertion of the eye muscles and you look at the planes of the insertions, the planes are parallel with the canals. And this is showing you the anterior canal, and this is showing you the posterior canal, and the lateral canal is not shown. And just to remind you that if we look at the eye movements that are generated by each canal, the horizontal canal generates a horizontal eye movement. The anterior canal generates an upward eye movement. Remember that if you might say, well, with a nystagmus, an anterior canal generates downbeating. Well, remember that nystagmus is made for the saccade, which is the fast phase, not the slow phase vestibular response. So the vestibular response is upward, but the saccade is going to be downward. The posterior canal generates a downward eye movement. Again, if you're naming a nystagmus that's generated by the posterior canal, it would be upward. And the otolith is torsional, and a lot of times we forget that it does a tilt. When we're talking about the canal planes, the canals detect the planes of angular motion, and so it's named as if you were in an airplane. So pitch is up and down, roll is turning on the side, and yaw is going transversely in the plane of motion. And when we talk about linear motion, its reference is that to a boat. So again, we're talking about surge, we're talking about heave, and we're talking about sway. So you have the lower motor neurons that are generating the eye movement, and then what you need to look at is the control eye movements down, the control centers from the cortex down onto the lower motor neurons. And so if you recall, there are 6 different types of eye movements, and there are 3 that hold the image on the fovea, and then there are 3 that change the gaze. And so if we look at visual fixation, with any of these eye movements, what you do is you look at what the target's doing and you look at what the eye is doing. And with visual fixation, you're holding an image stationary, or the stationary object on the fovea when the head is still. With the vestibular ocular reflex, the target is still and the head is moving, and you generate an eye movement that is equal and opposite to the head movement to try to stabilize gaze. With the optokinetic reflex, it holds an image stable on the retina during sustained low-frequency head rotation. So if you look at my eyes, what you'll see is an optokinetic reflex. And you generate that, again, to maintain a stable whole visual surround. With shifting gaze, you have the pursuit system where you need a visual stimulus. And you need to track it when it's moving in the horizontal plane or in the vertical plane, again with the head still. With saccades, it's jumping from 2 points or scanning. So you look at one target, then you look at a second target, then you go back to the original target. Again, the head is still and the eyes are moving rapidly and conjugately. And with vergence, it's being able to look at near distance and being able to look at far distance. So the vestibular nuclear complex, which we saw, which was at the junction of the pons and the medulla, is going to be responsible for generating 3 different eye movements. It's going to be responsible for generating the vestibular ocular reflex, pursuit, and the optokinetic reflex. So in theory, you need to evaluate all 3 in order to determine whether or not you have central involvement or whether or not you have peripheral involvement. The gain of the vestibular system, which is basically the output of the vestibular system, is going to be modified by the amount of vergence that you have in terms of if you're looking close to the target or far from the target. And usually, if you have deficits with smooth pursuit, you'll also see a downbeating nystagmus. So that's kind of some things that you should look for when you're doing your clinical exam. So I gave you an appendix. I gave you a big handout, and then I gave you an appendix on the end. And so if you look at the appendix, it's a very detailed, the first pages of the clinical exam. Realize that you always do a neuroscreen, and what you're looking for is central nervous system deficits. So you do a motor screen, a cognitive screen, a sensory screen, and something that a lot of times we forget is an autonomic screen, because if you're talking about people with dizziness, you want to look for damage to the descending sympathetic system, which is going through the pons and medulla. So you're going to see Horner syndrome. So you'll see a small eye, you'll see a droopy eyelid, and you'll see anhidrosis or lack of sweat on the side that you have the lesion. You then need to do the ocular motor exam. And with the ocular motor exam, you always need to observe, and you need to observe the position of the head and the body, because a lot of times the head might be tilted towards the side of the lesion. You need to look at the position of the eyelid. You can see ptosis, so you can have drooping of the eyelid on the side that you have issues. You want to look at visual acuity and confrontation or visual field deficits. You want to look at alignment of the visual axes with the cover and the uncover test. You want to look at the pupillary light reflexes. You want to look at the ocular motor range, so you want to look at the 9 plane of eye movements. And then once you're done with that, then you want to look at the ability to hold the image on the retina, shifting gaze, and positional testing. And so what we're going to do today is we're going to concentrate on the ability to fixate, the ability to hold the gaze, and the ability to perform the VOR. And then once you're able to do that, then do positional testing. So an article came out in 2015 that was done by Vannucci's group in Italy. The acronym that they use for it is standing. So that's basically what I'm going to talk today about, is this algorithm that they came up with. And it's used to differentiate central from non-central acute vestibular lesion. It's intended for patients who have symptoms of dizziness and vertigo acutely, so it's within the first 5 days, so it's when they're admitted into the emergency department, with no overt neurological signs. So you've done your neuroscreen, you see that there's nothing wrong with them, except for the fact that they have dizziness and vertigo. And then what they try to do is they try to differentially diagnose in terms of determining whether or not the person has BPPV, a unilateral peripheral vestibular deficit, or a central vestibular disorder. And what they do is they break it down into 4 steps. So it's a bedside exam, and their testing is performed with video Fresnel lenses and with video oculography, because these are subtle eye movements, and you need to amplify the eye in order to be able to see it. And then the other reason is if you have a peripheral issue with the vestibular system, so you have damage to the hair cells or the 8th cranial nerve, you can suppress the nystagmus with the smooth pursuit system. So you might not see the nystagmus unless you block fixation with the goggles and ask them to perform the test. So the first step that they look for is they put on the goggles and they look to see whether or not the person has a spontaneous nystagmus. If they don't have a spontaneous nystagmus, then they'll do positional testing. So that's the first step in the algorithm. The second step is if they have a spontaneous nystagmus, they look for what direction it's in. Then once they've determined the direction, then they'll have the person look with eccentric gaze, 30 degrees off to the side and 30 degrees up and 30 degrees down, to determine if it's a unidirectional nystagmus, which indicates it's a peripheral lesion, or if it's multidirectional nystagmus, which means it's a central lesion. Then they if they suspect it's peripheral, they'll do a head impulse test, and the head impulse test indicates a peripheral lesion. And in 60% of patients with, or 65% of patients with central deficit, the head impulse test is negative. And then the last thing that they do is if all the testing has come out negative and you still suspect that they have a central problem, you take them up and you stand them. Realize these are a bunch of MDs, so they don't stand their patients. But you stand them and see what their balance is like, and if their balance is off, then it suspects that it's a central lesion. So this is what their algorithm looks like. You can get it off the internet. NIH gives you the article for free. And I'd recommend that you look at it. And the first step is you put the goggles on and you look for nystagmus. And if they have no spontaneous nystagmus, then you do positional testing, and if it's positive, they have BPPV. If they have a spontaneous nystagmus, the next thing you do is you look at eccentric gaze. If it changes direction, it tells you it's central. If it doesn't change direction, you do the head impulse test. If it's negative, it's central. If it's positive, it tells you it's a peripheral disorder. If none of this comes out positive, you stand the person, and if they have to stand with assistance, then you suspect that it's a central vestibular dysfunction. So it looks easy, right? They looked at 98 patients who consecutively came into the emergency room. On average, it takes them 10 minutes to perform the test. Of the patients that came in, 16.3% had central vertigo. It has a high sensitivity and specificity and good inter-observer agreement. So they claim that it's a good test, but you can always improve on it. So what I did is I took some tests that have been done at Hopkins and added it, so we made it a 12-minute test instead of a 10-minute test to see if we can get better outcomes in terms of diagnosing. So the first step that you have to do, and my other comment is that if you treat vestibular patients, you know that the first thing that you do should not be positional testing, because if you do positional testing, they're going to lose their cookies on you, and you're going to miss the ocular motor exam. So what I'd like to do is I'd like to reorganize this, and I'd like to add something to it and hopefully make it a better test. So the first step that you want to do is you want to look at the static vestibular tone. And what I'm going to do is I'm going to tell you what you're looking at physiologically, and then I'm going to tell you what it is that you're going to find based on what the physiological sign is. So the first one is static vestibular tone. So we know that with the vestibular system, you have the inner ear that's located on both sides, and you have the 8th cranial nerve that's located on both sides, and it's going to the vestibular nuclei complex that's located on both sides. So if we want our eye still, and we're just sitting there at rest normally, you have a resting firing rate of the vestibular nerve, and you have a resting firing rate of the vestibular nuclear complex. So realize that this system is made for movement. So those nerves, And those cells are constantly firing. And they fire at a rate, if you're talking about the semicircular canals, the nerve is firing at a rate of 90 spikes per second, which in physiology is huge. And the central vestibular nuclei are firing at 30 spikes per second. So you have to have a balance between the sides, and you have to have a balance within the otoliths themselves. And the otoliths, as you know, are two sacs, which are the two sensory epithelial areas. So you have the maculae of the utricle and the maculae of the sacculus. And so you have two structures that are detecting 3 degrees of movement. If you look at the maculae, they are comprised of hair cells. They have a gelatinous mass with otoconeum that are sprinkled on top. And what they're going to detect is a tilt of the head, and they're going to detect translational movements. So you're moving through your environment this way. So you're swaying forward and back, or you're going up and down in an elevator. And what the hair cells end up generating is your vestibular spinal reflexes, so protective extension and torsional tilt of the eye that comes in with the utricle. So one eye drops relative to the other eye. So normally, if this is coming in from the otoliths, from the maculae, and it's going to the vestibular nuclear complex, which is at the junction of the pons and the medulla, you can see that if our head is at rest, and we're just sitting here, that our resting firing rates are the same between both sides, both at the level of the vestibular nuclear complex at the central nervous system and down at the peripheral nervous system, being the cranial nerve 8, or the vestibular nuclear complex. If you have damage to the vestibular system, and it could be to the central structure, so this could flatten out to 0 degrees per second, or if you have it to the peripheral system, again to the hair cells within the maculae or the 8th cranial nerve, what will happen is you'll get an imbalance between the two sides. And so your body will think that it's tilting to the left, and if it thinks it's tilting to the left, you're going to right your head to the right, okay? So what will happen is you'll have an ocular tilt reaction towards the side of the lesion. And this is important. It's your first observation that you have in the clinic is the head erect, and is it tilted? And if it's tilted towards the side that it's tilted towards is the side that's going to be involved. And that's an important thing to remember. So this is a gentleman who had a lateral medullary syndrome. So he had a small stroke that's on, if you look at this, the right side, right? Because his head is tilted towards the right. And what you're seeing is what's referred to as an ocular tilt reaction. So he doesn't have cervical spine dysfunction. He has damage to his medial vestibular nuclear complex. And if you look at his eyes, the right eye is smaller than the left eye. The right eye is dropped relative to the left eye. That drop of the right eye relative to the left eye is referred to as skew deviation. So skew deviation is a hypotropia, where one eye is dropped relative to the other eye. And the side that it's dropped in is the side that's involved. So you can tell that he has a right vestibular dysfunction. He has lack of ocular counter roll. Normally, when you tilt your head to the side, the eyes will roll, and his don't on that side. They stay, where they are. Again, you have the head tilt reaction, and he's going to have a tilt of perceived vertical. And again, this is due to damage to the otolithic pathways. And so physiologically, this is a normal person, and they roll their head, and you can tilt their head, and you can see their eyes roll, right? Well, this is somebody who has a vestibular deficit, and you can see that when he tilts his head to the left, the eyes don't roll. So again, this man would have left vestibular dysfunction because the head tilt is towards the left and you don't get that ocular counter roll. So this is a very fancy diagram showing you the semicircular canals in the otolith, and because this is the otolithic system, it's coming up through the vestibular nuclear complex at the pons. It's crossing over and ascending up to the thalamus and then going up to cortex. So in the area that we're talking about, before the crossing, you're going to end up having an ipsiversive tilt and, again, dropping on that side of the head of the eye. And then when you get above the crossing, it goes contraversive. But that's not what we're talking about tonight. So it's ipsilateral is what you're going to end up seeing with this patient. So the first part of our algorithm is looking at observing the person's head. And if they have skew deviation, where one eye is dropped relative to the other, they have a hypotropia. On the side that they have the hypotropia is the side that's involved. You do not see skew deviation with a peripheral lesion, but in 39% of people with central lesions, you'll see a skew deviation. So that's the first thing that differentiates a central from a peripheral. The next thing that you have to look at is the static imbalance between the two sides of the semicircular canal. And again, normally we have a balance between sides and between the coplanar planes. So if this is now coming from the semicircular canals and it's projecting to the vestibular nuclear complex, again, you have a balance of firing rate between the vestibular nuclear complex and you have a balance of firing rate between the nerves that are coming from the semicircular canals. If you, the other thing that you need to balance between is the pairs of canals. So if you remember the alignment, the left posterior canal is in the same plane as the right anterior canal. You have these canal planes. So you have to have a balance of the left side with the right side and the posterior canals with the anterior canals in order to have a nice stable eye. So what happens with the unilateral vestibular dysfunction? Well, if you have a lesion to the vestibular nuclear complex or to the 8th cranial nerve, what will happen is this side will go quiet, the right side will go quiet, and the left side will continue to fire. So if the left side continues to fire, the head's going to think that it's turning towards the left when you're just sitting still. And so what will happen is you'll generate a slow phase vestibular response to the right and a fast phase saccadic eye movement towards the left. So you'll see a left beating nystagmus. So the nystagmus always is named for the saccade and it always beats towards the side opposite the lesion. So that's an important thing to know for your quiz. I'm teaching for the test, okay? So, if you have a right-sided lesion, you have a left beating nystagmus because it always beats towards the side opposite of the lesion, and it's due to a tonic imbalance in the resting firing rate of the vestibular system. And so what happens is, this is a fancy picture showing you, this is the 8th cranial nerve going to the vestibular nuclear complex, and how you have different cell types within the vestibular nuclear complex. And what happens is these different cells coordinate the two sides of the head. So if you have damage to the 8th cranial nerve or to the vestibular nuclear complex, initially everything shuts down because your body doesn't want to make a mistake. And then about 5 days after it shuts down with a peripheral lesion, what will happen is everything will come back online and the proportions will start to be developed. So acutely, in the first 5 days after a peripheral lesion, you see nystagmus just sitting there, looking in the mirror, okay? I mean, my husband, one time, he had vestibular neuritis, and he called me up at work, and he said, "Oh my God, Janet, I have a spontaneous nystagmus towards the left." And he's an engineer. I said, "How do you know that?" "Well, I looked in the mirror, and I looked in the bathroom, my eyes are jumping like this," and I thought, "Oh my God, I talk too much at home." So anyhow, so you can see it, you know, if you're good. Then, after 5 days, when you see compensation, you no longer see it in the day or in the light because the smooth pursuit system is canceling out the nystagmus. So the difference between a central and a peripheral lesion is a peripheral lesion, you will see the spontaneous nystagmus in the light for the first 5 days, and then you'll only see it in the dark for up to 8 years. Versus if it's a central lesion, you'll see it in the light and in the dark because the pursuit system isn't working and it can't cancel it. Okay, so that, again, is an important point. So how we look for spontaneous nystagmus, or an imbalance in the resting firing rate between the two sides, is by using some type of video oculography or Fresnel lenses, because what you need to do is block fixation. And so with a peripheral lesion, acutely, you'll observe nystagmus with and without fixation for the first 5 days. And then once they've compensated, so after 5 days, you'll only see it if you're wearing goggles. And then again, the direction of the nystagmus is named for the fast phase, and it's always the side opposite the lesion will be the direction of the nystagmus. With a central nystagmus, it's always there. It's present in the light, it's present in the dark. It will be there for the rest of your life because it's a permanent deficit. So hopefully this will work. This is a person who's in the middle of a Meniere's attack. Okay, so again, this is right, this is left. And so if you look at the eyes are being very quickly this way, correct? Doesn't matter if you've got looking at the right eye or you're looking at the left eye, because the eyes are yoked together, okay? No matter what position you put this patient in, the reference point is always as if they're sitting upright. So what direction of the nystagmus is it? It's right. So which ear is involved? The left. Okay. Okay, so according to Alexander's law, if this is a peripheral lesion, the first step, remember, is you look to see if it's spontaneous nystagmus. Then the second step is you have the person move their eyes eccentrically, 30 degrees to the right, 30 degrees to the left, 30 degrees up, 30 degrees down. Okay? If I turn my head and I have a left beating nystagmus, if I turn my head 30 degrees towards the left, the amplitude or the frequency will increase. And if I turn my eyes 30 degrees to the right, the amplitude will decrease. Because anytime you look towards the direction of the fast phase, you will have an increased intensity in nystagmus. So it doesn't change direction. It's unidirectional. So a peripheral lesion will always be unidirectional, no matter what it is that you do to them. So this is a little old lady.
Yep.
So what direction is her nystagmus? Left beating.
Look to the left, Marie. With your eyes, look to the left.
And she does what every little old lady does. She moves her head and not her eyes, okay? So then she's got to plant her hand on top of her head and then have her look with her eyes. And if you see, when she looks towards the left, you have an increase in frequency of the nystagmus.
This is my left. Yep. One way, that's right. Go one way and then the other way. Look to the right.
And as she looks to the right, when she looks to the right, it'll slow down a little bit.
Keep your head still.
Okay, so no matter what direction she looks at, that's a left beating nystagmus, right? Okay, so, but remember, we have 3 planes of motion. And I didn't talk about this, but the vestibular nuclear complex is organized by those 3 planes. So you can have a lesion to the vestibular system in the horizontal plane or in the vertical plane, depending on where you have the lesion. So you can have imbalance in vestibular tone in the pitch plane. So that's between your anterior and your posterior canals. The nystagmus that you tend to see that's central in origin is a downbeating nystagmus. And it usually increases in intensity if they look laterally or if they look down. And this is really common with people who have issues with hypertension. If they have hypertension, a lot of times their pons will have little mini infarcts, and the little mini infarcts are around the area where the eye tracts are going in and out, and so they'll end up with a downbeating nystagmus. Upbeating is very, very rare, and if you see it, it looks, increases in intensity when they look up. With the downbeating nystagmus, those are the structures that are shown in red. They tend to either be bilateral involvement, if it's of the flocculus, which is, as you recall, is part of the cerebellum, if it's on the midline of the flocculus, or if it's in what's referred to as the paramedian tracts, which again are on the midline. With upbeating nystagmus, which you see in blue, again, it tends to it's actually due to a damage within the vertical system, but you only have one side that's out and not both sides that's out. And no So when we look at the canals and we look at imbalance in tone between the two sides, if it's a peripheral lesion, you usually see horizontal torsional nystagmus that beats away from the side of the lesion of a constant velocity. Fixation will suppress it with the smooth pursuit system, and it's a unidirectional nystagmus. If it's a central lesion, it can be horizontal torsional, again beating away from the side of the lesion. You can have vertical nystagmus of variable velocity, and you're unable to suppress it with the smooth pursuit system. Okay, which next leads us to the neural integrator. Okay, with the neural integrator, this is the person's ability to hold their gaze eccentrically. So to be able to look 30 degrees to the side and maintain that position there. So what it does is it takes the signal, the eye signal that causes you to move your eye, it then mathematically integrates it to create a position holding signal. And so the ability to hold that embedded within a gelatinous mass or the cupula. And this is showing you a micrography of the cupula. Well, those hair cells, depending on which way the kind of cilium, depending on which way you turn your head, you can generate two eye movements with the same canal in whatever plane you're looking at. And the two sides, just to remind you, they work together in a push-pull relationship, again, in those coplanar pairings. And with the push-pull relationship, you can see that if I turn my head to the left, what happens is the direction of the eye movements will always be in the direction of the flow of fluid within the canal. So if you look at my bottle of water, if I turn the bottle towards the right, the fluid in the bottle moves relatively towards the left. And if I turn the bottle towards the left, the flow of fluid is relatively towards the right. Well, the same thing happens with the canals. So you can see that what will happen is if I turn my head to the left, my eyes will move to the right, and what will happen is I'll get excitation on the right side because I'm pushing on the cupula, and because of the pull of the flow, I'll get inhibition on the left. And this is AVOR, which is an app that you can download onto your phone and onto iPads and that kind of stuff, and it's showing you the inhibition and the excitation of the two canals and how they work together. And this is true with all of the canal planes. So with the head impulse test, you apply a brief, transient, passive, high acceleration head movement. We're talking 150 degrees per second. So this isn't a little, this isn't a slow movement. It's a high velocity movement. Because if you're slower than that, what will happen is the other side can work for you and you won't see a corrective saccade. So normally, if you turn the head, the response is you maintain fixation. And the gain of the VOR is output over input. So the output is eye velocity, the input is the head velocity, and normally your gain is equal to 1. Well, what happens when you have a vestibular lesion is if you rapidly turn the head towards the side that you have the damaged vestibular system on, what happens is that you don't get a compensatory response. And so if I rapidly turn my head to the right, my eyes should move towards the left. What will happen is it'll look like they'll lag behind and they'll get stuck in the head when you turn the head. Now all of a sudden you see a really rapid jump on target, which is a corrective saccade. It's a refixation saccade. And in the first 5 days in the acute phase, you will see a corrective saccade if it's a peripheral lesion. But after that, you see covert saccades, where if you make the head movement, you see, if you have special equipment, you can see little microsaccades that occur to keep the eye on target. And again, that's during the compensatory phase. And this is showing you some of the equipment that you can use to look for covert saccades when they're making the eye movements. So again, if it's a peripheral lesion and you do a head impulse test, 92% will have a reduced gain towards the side of the lesion. So that's very, very high. Again, overt saccades you see during the acute phase in the first 5 days, and covert saccades you see in the compensatory phase. With a central lesion, with a head impulse test, it's negative in 61% of your patients. So you won't see anything, okay? But if they get the nerve right as it's exiting the vestibular nucleus, then you'll see a positive response. So 39% of your patients will have a positive head thrust test. So it's a pretty good numbers, but not the greatest. So you look to see whether or not they had a spontaneous nystagmus. If they had a spontaneous nystagmus, you then move their eyes eccentrically to try to figure out if it's unidirectional, which means that it's a peripheral lesion, or if it's multidirectional, which means it's a central lesion. Then you do a head thrust test. If it's a peripheral lesion, you're going to end up being positive in 92%. If it's a central lesion, it's only going to be positive in roughly 39%. So again, that's the difference. So if all of that is negative, then the next thing that you do is you stand the person up and you look to see and walk them and look to see whether or not they need to be held. So remember that with the otolithic system, it's responsible for generating your protective extension and for torsional tilt of the eye. So if you have a central issue, they're going to have more severe balance issues, and they're not going to be able to stand unless they require assistance or they require assistance from somebody else. So again, if they have no spontaneous or positional nystagmus, if you stand them up, they're going to have difficulty maintaining an upright control. So this is the part that I like. So if that all comes out negative, and even if it doesn't, then you do positional testing. And this is probably going to be the fastest description of BPPV I've ever done in my life. So, as you know, with BPPV, it's a mechanical disorder of the inner ear that's caused by abnormal stimulation of one of the three canals. The most common canal is the posterior canal, just because of the position that we sleep in bed. It can be the anterior canal or it can be the lateral canal. So if you look at this diagram, this is a picture of the utricle and this is a picture of the sacculus. And the utricle is attached to the three semicircular canals. So this is the maculae right here. And you're going to see that the oticonium are attached, and the oticonium, they cycle just like skin. So skin, every 28 days, the keratin cells, the keratocytes, come to the top of the skin and they slough off. And you have some people who have nice, supple skin, and other people who have dry skin, and it just breaks off in huge chunks. Well, the same thing goes with oticonium. You have some people that just get a little break off, and we can deal with it, and then you have other people who have huge clumps that come off. And you can see that the oticonium falls off, and then the person lays down in bed, and when they lay down in bed, they settle to the most dependent part of the ear, and then when they sit up in the morning, the rocks roll down, and they get stuck behind the ampulla in the posterior canal. And so then anytime they tilt their head back, the rocks roll, pulls on the fluid, you generate BPPV, you see nystagmus, and they feel dizziness. So usually when somebody has BPPV, there are two questions that you have to ask them. Do you get dizzy when you roll over in bed? If they get dizzy when they roll over in bed, or if they get dizzy when they're getting out of bed, they're 4.3 times more likely to have BPPV. But what you have to be careful about is that if they're getting dizzy when they sit up or when they stand up, that it's not orthostatic hypotension, especially in an elderly person. But the other signs and symptoms that you'll see if the vertical canals are involved is they'll get dizzy when they look up, which is top shelf syndrome. If they move their head quickly, if they bend, people who have anterior canal BPPV will complain that in the morning when they get their coffee and they look at the newspaper, as soon as they bend their head, they get dizzy. You don't hear that with somebody with posterior canal, you hear that with somebody with anterior canal. With lateral canal, they complain of dizziness when they're up and walking around, which is very different than somebody with vertical canals. Vertical canals, if they have their head still, they're not dizzy. It's only when they move tilt their head back that they get in trouble. With lateral canal, they'll complain of dizziness when they check their mirrors when they're driving. They'll complain of dizziness when they turn their head in the horizontal plane. I had a school teacher who would come out of her classroom and turn the corner too sharply out in the hallway, and she'd get sick. So, you know, it's something where the horizontal plane is really bad. And then sometimes if you bend forward in the pitch plane. So, remember, with identifying the canal that's involved, it's important that you know the orientation of the canals. So, with that posterior canal, the ampulla is 20 degrees below the horizontal, or the horizon. Because of the dislocation, it's very easy to treat. With the anterior canal, the ampulla is almost vertical. It's 70 degrees from the horizontal. So it's very difficult to try to clean out that anterior canal. And then with the lateral canal, you have a 20 to 30 degree nasal occipital angle, And the lateral canal, the ampulla, is up on the top, on the nasal side. So you would think the rocks would slide up, but they don't. So if you look at the angles of the canal, we're always taught in school that they're at 90-degree angles to each other, and that's a lie. So if you look at the sagittal plane, the anterior canal is 35 degrees off of the sagittal plane. And why that is important is it changes the axis of rotation. So you will see primarily downbeating nystagmus, and you might see a little bit of torsion. With the posterior canal, it's 51 degrees off of the sagittal plane. So with it, you will see a strong torsion and a little bit of upbeating. So again, the proportions of vertical versus torsion is different depending on the canal that's involved. So if you want to test the canals, what you do is you do positional testing. And you have this algorithm, and I'm not going to go through it in a lot of detail, but you can look at it and refer back to it. If you do a Dixell-Pike test, what you're looking for is nystagmus, and you have to have video oculography or frontal lenses in order to be able to see it, because in 50% of people, they'll be able to suppress it. The other thing is that if they're on meclizine or Bonine or Valium or any one of the other central nervous system suppressants, you won't see the nystagmus. If you're concerned about them vomiting, Zofran is what I recommend because it is not a central nervous system suppressant, but it is something that reduces nausea. So if you see a torsion towards the floor and upbeating nystagmus in the Dixell-Pike position, the lowermost ear is the posterior canal that's involved. If you see downbeating nystagmus, again, it's the anterior canal, or you can see horizontal nystagmus, which then you do the supine roll test. So I think you're all probably familiar with the Dixell-Pike test, and you have the person sitting long sitting, turn the head 45 degrees to the right, drop back into 30 to 40 degrees of extension. I do more extension now than I used to do. And you want to maintain the position for 45 seconds. And again, you want to avoid vestibular suppressants, and you want to make sure that you're breaking fixation by wearing some type of goggles. The psychometrics on it is very good. If you're down in the Dixell-Pike on the right side, you're testing the right posterior canal. If you sit them up, go down to the left side, you're testing the left posterior canal. And this is showing you how if you turn the head, and in this case, this is to the left, the debris is in the left side, so it's the rock, and you can see as you drop the head back into that 30 to 40 degrees of extension, the rock rolls. When it rolls, it generates a torsional and upbeating nystagmus. So what you see with posterior canal is if you drop the head back and it's on the right side, the posterior canal is parallel with gravity, the rocks drop. You see a counterclockwise and upbeating nystagmus. If it's the head right is involved, you sit them back up. When you drop them down towards the left, the canal is now perpendicular to gravity. You see no movement, you see no pain. There should be a 1 to 40 second latency before onset, less than 60 seconds, and fatigues with repeated positioning. So this is the classic nystagmus that you all see in the head right position. I'm just dropping the man down. And I drop him down, and when you tell him, the cue is you tell him to look up, not open his eyes, but you look up. And if you can see, you're seeing an upbeating and a counterclockwise nystagmus. And this is classic, as you know, BPPV involving the right posterior canal. And then once it settles down, I'll sit him back up. And when I sit back up, you're going to see the eye go side to side. That is a normal VOR response. That's just because he's turning and flipping to sit back up. So it's going to come. Okay, so now I'm sitting him back up. That's, again, normal VOR, not lateral canal. And now what you're going to do is you're going to see an unwinding. So now you're getting an inhibitory response because the debris reversed directions. And now you're getting downbeating with a clockwise turn. Okay. So the other thing that you can see in the test positions are you can see anterior canal BPPV. And anterior canal BPPV, remember, the ampulla is on the top part. So its orientation is very different than the posterior canal. So If you look at this picture, this is showing you the right Dix-Hell pipe position. And this is showing you the canals on the right side and the canals on the left side. And if you put debris on in the right canal, on the right side, you'll see that the rocks will roll and they'll settle down to the lowest part of the ear because it's almost vertical. It's 70 degrees from the horizontal. And when you drop the head back, it's at a 40-degree angle, so if there are rocks in there, they'll roll. If you have debris on the left side, the same thing will happen. Because of that 70-degree orientation, the rocks will roll. So the problem with anterior canal BPPV is you can have a positive response in both the head right and the head left position. 20 years ago, we used to teach that if you put them in the head right position, you were testing the left anterior canal. We now know because of that orientation and the location of where the ampulla is, that in the head right position, you're testing both the left side and the right side. So remember that you're going to get primarily a downbeating vector of eye movement. And in 50% of patients, you're going to see no nystagmus. No torsion, sorry. You'll see a downbeating nystagmus, pure downbeating with no torsion. In the other 50%, what you'll do is you'll see a very small amount of torsion. And the direction of the torsion will determine the ear that's involved. So, if I drop the head back into the head right position, and I see a counterclockwise nystagmus, so it's beating towards the floor, and a downbeating nystagmus with counterclockwise torsion, it's the right ear that's involved. If I drop the head back in the head right position, and I see torsion towards the uppermost ear, so it's clockwise, then it's the left ear that's involved. And whatever nystagmus you see on the right side is the same nystagmus that you'll see on the left side because of the orientation of the canals. Again, latency is 1 to 5 seconds, vertigo is less than 60 seconds, and it fatigues with repeated positioning. If you don't get anything by bringing the head to the side, then I bring it straight back. And you add just a little bit of extension, and when you add the extension, the rocks will go around the loop, and you'll end up generating a nystagmus. So this is a woman who came in, and her nystagmus looks the same if I'm in the head right, the head left, or the straight back head hanging position. And if you look at her, she's in the head right position. And if you look at her eye, what direction is the nystagmus?
Down.
Well, it's downbeating, right? But no matter what you do, it's a downbeating nystagmus. And when I sit her back up, it should reverse direction and go upbeating, but in her case, it just gets quiet. Okay, sometimes it goes a little bit on an angle to the right, but it's primarily downbeating nystagmus. So with her, can you identify the canal that's involved? No. Okay, you know she's got anterior canal, but you don't know what else it is. Okay, then this is another person. Okay, so the head's dropped back.
At first.
Okay, so yeah, a little bit of torsion, right? A little bit of clockwise torsion and downbeating. So if it's going clockwise, right? What direction is it? I mean, what canal's involved? If it's a little bit of right. Okay, so the anterior canal. If they're in the, doesn't matter if they're in the head right or the head left position, right? Now he's moving. Now she's moving it. So if the head is back, right, and you see a right beating nystagmus, it's down beating and I'm sorry, not right beating. If it's a clockwise nystagmus, so it's beating towards the right ear, it's the right ear that's involved. Okay? So if I have my head turned 45 degrees to the right and I drop back and it's beating down with a twist towards the right ear, it's the right anterior canal. If I turn my head to the left, drop back, and I see it going down with a twist towards the right ear, it's the right ear that's involved. It's a clockwise twist. Does that make sense? Okay, so no matter what position you put it in, you're going to see downbeating with a twist. Okay, so if you don't see anything, the next thing that you look for is lateral canal BPPV. And this is the important one. This is determining central from peripheral nervous system, okay? So, I'm going to back up a minute. With downbeating nystagmus, if you look at the literature 30 years ago, they said that that was always a sign of central vestibular dysfunction. Well, I think that we know now that that's not true. That they actually say 17% of BPPV is anterior canal BPPV, and I think we weren't accurately diagnosing it because we didn't have the equipment. We weren't using video oculography. And the other thing is with the internet now, people are diagnosing themselves and performing exercises on their own, and they're doing them incorrectly. And I think they're throwing the rocks everywhere, and they're creating anterior canal BPPV. So I think things have changed over the years. With lateral canal BPPV, again, by definition, it's proximal, it's linear, and it's bidirectional changing. And that's the important thing. This is going to determine whether or not it's central or whether or not it's peripheral. So, if the person's laying on their back in the transverse plane, when the head is to the right and when the head is to the left, it should reverse direction. And it will always beat either towards the floor, which is geotrophic, or it'll beat away from the floor, which is apogeotrophic. If you see that directional changing, then what you do is you sit them up and you compare their head forward and their head back. And again, what you should see is a change in the direction of the nystagmus with their head forward versus with their head back, but it should always beat towards the floor or away from the floor by definition. And the reason for the switching is because, remember, flow towards the ampulla is excitatory and flow away from the ampulla is inhibitory. So this is my canal, and I recommend that you make one if you don't have one. And this is my lateral canal, and this would be my ampulla. So I'm sitting back up like this. So if my rocks are here, my rocks, if they're on this side of the 30-degree angle, they're going to fall down this way, right? So if I tilt my head back, they'll further fall that way. So it'll pull away, correct? And if it's pulling away, it's getting inhibition. So whatever you saw when I was sitting upright and moving is just going to continue when I put my head back. Now, if I flip my head forward, what will happen is all those rocks will move towards my nose. When they move towards my nose, it will push on the cupula, and I'll get an excitatory response, so the direction of my nystagmus will reverse direction. You have to see that in order for it to be lateral canal BPPV. If you don't see the reversal of direction, it tells you that it's central nervous system involvement. So, again, we have this 20 to 30 degree angle, and what's important is, and this took me a long time to figure this out, this is the left side of the body, but this is the right ear, okay? So it looks so once you get that reference frame, then you do okay. This is the utricle, this is the ampulla, and then again you have a 20 to 30 degree angle. Any debris that is on your right side of the 30 degree angle would create a geotrophic nystagmus towards the floor. Any debris that's on the left side, so in this initial ampullary segment or on the cupula, is going to generate apogeotropic BPPV or nystagmus away from the floor. So again, with positional testing, you go through the algorithm, you do the supine roll test, then what you do is you're going to look for the person, the nystagmus in the supine roll test. And again, you can read this on your own time and it'll make sense to you. But what you do is the supine roll test, where you turn the head 90 degrees to the right, drop them back into 30 degrees of flexion, you look for the direction of the nystagmus. It'll either be towards the floor, horizontal towards the floor, so it'll be right beating, or it'll be away from the floor, which would be left beating. Then you put it in neutral or in the center, and you hold it there for 30 seconds, all of them, and then you turn the head to the left 90 degrees and hold it there for the second. So what you will see is, if it's a bird's eye view, if you drop the head back and they're 90 degrees to the right, if you see a right beating nystagmus, head right, and you see a left beating nystagmus, head left, it's always beating towards the floor, so it's a geotrophic nystagmus, so they have geotrophic lateral canal BPPV. If, when their head is to the right, you see a left beating nystagmus, so it's beating away from the floor, so it's apple geotrophic, and you turn the head to the left, and it's beating away from the floor, so it's a right beating nystagmus, it reverses direction, right? It went from a left beating to a right beating. It's away from the floor, so it's an apogeotrophic BPPV. And the reason that you see this is, if you drop the head straight back, I'm just doing it, it's not how you do the test, but I'm just showing you this so that you can see it. You can see that all the rocks are settling, or they're pulling away from the cupula, okay? So that's created an inhibitory response. So in this case, you're getting a right beating nystagmus. If I turn my head 90 degrees to the right, the rocks just continue to move towards the occiput or away from the cupula, pulling on it, which continues with an inhibitory response. If I go from center or from neutral, where all the rocks are moving away, and I turn my head now towards the left, well, what will happen is the rocks will settle, and when they settle, they push on the cupula, and you end up with excitation, and you end up with a reversal of the nystagmus. So this is what it looks like. This is a woman who treated, okay?
Yeah.
Okay, so I dropped her head straight back, just so that you can see it relative to your lifestyle. What do you see? Right beating nystagmus, okay?
It's as if it switched ears on you. To the right? Yeah.
Okay, and then what I'm going to do is I'm going to turn her head to the right.
Okay, now I'm going to turn your head to the right.
And that's normal VOR, that's just a head turn. Okay, and then now that she's in the right side, what you're seeing is what direction of nystagmus? A right beating nystagmus. And it's very quiet, right? It's not very impressive. It's not. So now what I'm going to do is I'm going to turn her head to the left. And you have to be careful because when I move my head to the left, I'm moving her 190 degrees, 180 degrees, which is a lot of input into the system. That's normal head turn, that's normal, that's normal. Now this is not normal, okay?
Yeah, I can feel it
So
now.
what you're seeing here is a left beating nystagmus, head left, and it's a greater intensity.
I guess I have rocks in my head. My husband teases me.
Okay, so with her, again, an inhibitory response is less than an excitatory response. So because on the head left side, she had the greatest intensity of nystagmus relative to the right, she has left-sided BPPV. And then the same thing you can see with apogeotrophic BPPV, except it's stuck on the cupula. So this, she's head left, and what do you see? Right beating nystagmus. Okay, now he's moving her back to a neutral position, and again, you see a right beating nystagmus. It's getting slow. And then when he turns her head to the left, right,
Even
to
when I
the
was doing
right.
the exercises.
and now what do you see?
I
The
know.
left beating nystagmus. Now, because of where it's stuck on the cupula, the side of the least intense with apogeotrophic BPPV is the side that's involved. I believe with her, it's the right side is the least intense, so she would have a right apogeotrophic BPPV. So that's this part of the algorithm. And then what we're going to do is just talk about lateralization. Again, it's the side of the greatest intensity, and it can also be the side of the direction of the pseudospontaneous nystagmus, but I'm not going to talk about pseudospontaneous nystagmus tonight. So, and this is again just showing you that the side of the greatest intensity for geotrophic is the side that involved, and the side of the least intensity is the side it's not. Okay, so if I have apogee geotrophic BPPV. My rocks are on this side. Okay, so they're going to fall this way, so they're going to get an excitatory response. If I'm geotrophic, they're falling away, so I'm going to get an inhibitory response. If I tilt my head forward, all the rocks, no matter which side of the ring they're on, are going to go to my nose. And if I tilt my head back, all the rocks are going to fall back towards my occiput. So when you do that, you reverse direction. So how you test for that is there's a lot of different tests, but this is the test that I like. I use the forward roll test. So you turn the head 90 degrees to the right, drop the head forward, maintain it there for 30 seconds, then turn it so that the nose is down, hold it there for 30 seconds, and then turn it towards the left and hold it there for 30 seconds. What you should see is, if it is a geotrophic lateral canal BPPV, it will stay geotrophic, which means it will reverse direction. So, if my head is turned to the right and I'm on my back and it's geotrophic, I'll get a right beating nystagmus. If I sit up and I bring my head forward and my head is turned to the right, it's going to be geotrophic, so now it's left beating nystagmus, right? Okay? So if it's geotrophic on my back, it's got to be geotrophic when I'm forward. Okay? That's another test question. So if it's central in origin, what will happen is if I'm on my back, it's geotrophic, and then I come forward, it's apogeotrophic. So what that looks like is if my head is turned to the right and I have a right beating nystagmus, when I sit up and I come forward, it now, instead of going to the left, it stays right. Okay? So what that's telling you is that if it stays geotrophic, it's the direction is going to be dependent on gravity. That is BPPV, because by definition, the nystagmus that you see is dependent on gravity, and it depends on where the location of the debris is within the canal. If it does not change direction, it's telling you that it's dependent on the position of the neck. So it could be central nervous system in origin, or it could be cervicogenic. So 50% of apogeotrophic BPPV is central nervous system in origin. So you always need to look for it. And patients with head injury, if they have damage to the otolithic pathways, will have positional nystagmuses which are not BPPV. So you've got to tease out when you're working with them. So just to reiterate, with lateral canal BPPV, again, it's linear, bidirectional in both the transverse and the pitch plane, 1 to 2 second latency of onset, usually lasts greater than 60 seconds. It lasts on average 3 minutes, 30 seconds because the velocity storage mechanism, which is the memory that you keep for the horizontal system, maintains it in memory for a longer period of time than for the vertical system. So it does not fatigue with repeated positioning, and again, it's more intense if it's geotrophic on the side that you have the nystagmus. So if it's a peripheral lesion, it's gravity sensitive. If it's a central lesion, it is not gravity sensitive, and it's based on the position of the head on the neck. Okay, so that is a lot to chew. That was that simple four-step evaluation that takes 10 minutes to do. Okay? So, another study came out by Newman Tolker from Hopkins, and he's been doing a lot of ER work and trying to come up with what's the best way, what does better than an MRI in differentially diagnosing a posterior fossa exam. And he describes HINTS, which is head impulse nystagmus test of skew. And it's a 3-step bedside examination. And again, they found it to be better than an MRI. With the patients, they find that if they have a normal head impulse test, if they have gazeable nystagmus, that's directional changing, and a skew deviation, so one eye is dropped relative to the other, so on the side that's involved is the eye that is dropped, that they tend to have central vestibular dysfunction. And again, if you have a false positive on the head impulse test, but you have the other two, it indicates that it's a central vestibular lesion. So again, the head impulse test is positive in 39% of central vestibular patients. It's positive if the lesion is to the medial vestibular nucleus. The gaze evoked nystagmus is due to a leaky neural integrator. It just means that it's not holding it in storage. And again, is if you have damage to the medial vestibular nucleus or one of the other integrators. The gaze evoked nystagmus, though, can be due to drugs, and it could be due to other damages. And then skew deviation, again, is rare in vestibular neuritis. And what they found is, which I like these statistics are, with the positive head impulse test, 39% with central, 92% with peripheral. With gaze evoked nystagmus, 56% in central, only 17% in peripheral. And test of skew, for the most part, you only see skew with a central lesion, and you rarely see it with somebody with a peripheral lesion. So, again, if you suspect a stroke, you want to look again for the normal head impulse test, the gaze evoked nystagmus, and the skew deviation. So, with central vestibular lesions, remember that you can have a positive head impulse test and no skew, but if you see the directional change in nystagmus, it's indicating that it's a central lesion. So in summary, brainstem lesions are often misdiagnosed. They're misdiagnosed more than what you think. That the symptoms frequently will mimic an acute vestibular syndrome that is peripheral in origin. But you need to do an ocular motor exam in order to determine if it is central or peripheral. Again, you need to not have fixation, because if you do it in room light, you're going to miss a lot of the stuff that you need to see to differentiate central from peripheral. So, do you have any questions?
Do you have the goggles?
Oh, I didn't bring them with me. No. Sorry.
I have a question. I read the Newman, the Hints articles, and I interpreted like the skew deviation test as like the alternate cover test, but you're describing it more as like just observing at rest. So
Well, it's both.
okay.
Because when you do, they are referring to hypotropia.
Mm-hmm.
And tropia is with binocular viewing, so you would see it when the person is just sitting and looking at you. If you have a hypophoria, you see with monocular viewing. And so the cover-uncover test looks for atropia and for aphoria. But when you're covering and uncovering, if they look normal when you're just sitting there, and then you cover and you uncover, and you see it, that's aphoria.
Okay. So would you normally just look at both?
I do both.
Yeah.
You know,
Because it could be normal at rest, but you wouldn't necessarily catch it until you do.
correct.
Yeah.
So I think, I was thinking about this in terms of, is this something that we want to teach to, emergency room physicians or just to PTs who are going in and triaging? This is a screen. This doesn't replace your neuro exam, and it doesn't replace your full ocular motor exam. Like, it doesn't talk anything about rebound nystagmus, and we all know that rebound nystagmus can only be from damage to the cerebellum, and it doesn't talk about the phorias and that type of thing. But I think it's a good place to start, and I think it gets people to think in terms of what the physiology is behind what it is that they're seeing. That the nystagmuses are due to an imbalance in both sides. The head impulse test is due to a reduction in gain. And that, if you're looking at eccentric gaze and you have issues with the neural integrator, that can only be a central, dysfunction. So I think it starts getting us to see patterns, and hopefully we'll miss less if we think in terms of patterns than, just in general. But you're right, you would do cover and cover. Any other questions? Yeah?
You didn't really talk much about treatment, but I'm just curious to see what your thoughts are on those big chairs, the Omniacs chairs that are very expensive, but
Correct.
do you have any thought on that?
Your success rate in the office is very high if you do, the canal repositioning procedure or any of the particle repositioning procedures. But, there are people who, for whatever reason, you
can't get into those positions, or you've tried and you can't get rid of it. And then I think for those people, it's very appropriate to try to send them for an omniacs. And the two centers that I'm aware of are in St. Louis and in Michigan, which are the closest. We have had issues where people have been rotated who end up with a canal jam, where when the debris goes from a wide area to a narrow area, it gets stuck, and then they can't unstick it. And we wonder if it's because it takes 15 minutes for them to go around if they're spending too much time upside down, and then it all just plugs. So, it's just something to think about. But if you have a patient where you've tried everything and they haven't gotten better, I would send them to another PT, because we all do it a little differently, and the variation that you do might be what the person needs to make the person better. And then if that didn't work, then I would try to send them to a chair and see if they can do it. Do you have a question?
Yeah, when you're talking about the assessment and doing a quick velocity head turn, do you have any clinical pearls regarding people that might have limited cervical range of motion?
I always like to go instead, initially it was described that you look at the person straight ahead and they turn the head 20 degrees to the side, to the right and to the left, and now we do off-axis rotation where we bounce it up and down to try to isolate the vertical canal pairs. The issue that you have is with people who have gaze evoked nystagmus, that if you get them to the outer ranges, that you can evoke it and then you can't see the corrective saccade. So what I try to do is I try to have them go off, 20 degrees off to the side, and then turn the head rapidly to the middle, and then go 20 degrees off to the side, and then rapidly go to the middle. And I think if they have cervical issues, you're better to go from an eccentric position to primary position than to go straight ahead out to the side. But it is an issue, and you just look at it as a limitation. What I would do in that case, as I'm thinking now, is if you don't see spontaneous nystagmus, if you put a vibrator on the neck, a shower massage vibrator, what we think happens is if the person has compensated with the cervical ocular reflex and they're suppressing the nystagmus, that if you put the vibrator on like the shoulder, they'll decompensate, and what you'll see is the spontaneous nystagmus. So I would look for that if I couldn't do a head thrust test on them. Any other questions?
Yes, another quick one. Do you find, is there, do you think, a difference in sensitivity with just Frenzels versus the video comments? We just have the regular Frenzels. I feel like we miss. I miss a lot of things, and I'm like, this seems like I should be seeing something, but I don't. It's just symptomatic that fits, it's just kind of.
No, they're not as good. So Frenzel lenses are magnifying glasses with a light source behind so that they can't visually fixate. So it's just like looking at the eyeball with a magnifying lens. Versus video oculography is, I can show one eyeball on a TV screen this big, and the person who comes in with them is sitting across the room and can see the huge jumping that's occurring. And there are some people now who are saying that you don't need goggles to evaluate somebody, because they say that video oculography is so sensitive that you're saying that people have things that they really don't have. Well, I disagree with them. I mean, you can very easily, you always have to start out in sitting, looking for spontaneous nystagmus in the dark for at least a minute, because it takes about 30 seconds for the central nervous system to lose memory of the signal that's coming in, and then all of a sudden you'll start to see the spontaneous nystagmus. And then what will happen is, if you drop them down into the Dixell Pike position and you change the position of the head, a lot of times their spontaneous baseline nystagmus will increase in amplitude. And then on top of that, then you'll see the BPPV. So it's really important that you identify what their spontaneous nystagmus is before you drop them down, so that you don't misdiagnose them as having something that they don't have.
What's the average cost
for that kind of equipment. $2,500, and it's worth every penny. And to me, if you don't have it, you're missing 50%. And a lot of the videos that we have of patients who they were not successful, they will have seen a therapist for like 8 months. And then they go to a clinic that has the goggles, and within 2 treatment sessions, they're back to work. So, my feeling is if you're a carpenter, you don't go to work without a saw and a hammer. And it's the same thing with vestibular rehab. If you don't have the goggles, then you're missing a lot. Any other questions?
You had said something like the anterior canal in PPV. It can be difficult to determine which side. How do you treat it?
I treat it with neck extension. So you have to get the canals back 60 degrees from the horizontal. And if I can get more, that's great, so that you get the debris to move around the rings, and you hold it there for about 2 minutes, and then you come up and you tuck the chin. And if they don't have that amount of neck extension, then I'll reverse wedge them on a tumble form and bring them back down. And sometimes there's just nothing that you can do about it. But that's usually how I try to do it if they're young and they're healthy. Any other questions? Then thank you.
Thank you.
Sharing the time and your wisdom with us tonight.
Yes, anyone would like to have some better Are there handouts?
There's an email you have to send to my
I can kind of understand.
Okay.